Good morning. My name is Callie Boyer. I'm the Director of Marketing here for Promises, and we are back with another PBHU webinar. Um, y'all, we have Olivia DeRozier this morning. She's our Director of Medical Compliance and Quality Assurance here with Promises, and we're going to be talking about cognitive bias and the hidden influences on pain care. Olivia, you can go to the next slide. I will be introducing her. I'm excited to introduce Olivia. Again, she's our Director of Medical Compliance and Quality Assurance here at Promises Behavioral Health. Olivia is a registered nurse with a Bachelor of Science in Nursing and brings more than 11 years of experience in behavioral health to her role. Throughout her career, she's worked across emergency services, case management, bedside nursing, and leadership nursing, giving her a well-rounded perspective on patient care. She's especially passionate about helping individuals achieve recovery and mental health stabilization with a strong commitment to serving underserved communities. In her current role here with Promises, Olivia helps ensure that the care we provide is safe, ethical, and grounded in strong clinical standards. She's deeply committed to integrity, collaboration, and creating environments where both patients and healthcare professionals can thrive. Outside of work, Olivia enjoys volunteering at local animal shelters, reading, and spending time in her garden. So please help me with joining Olivia. It's her first time here to PBHU. I'm very glad you're here with us. You can go to the next slide. I'm going to introduce Promises. So I know a lot of you know my spiel around this, but if you are new, Promise Behavioral Health is what makes PBHU happen. So we offer free CEs every single month, and we've been doing so for almost 3 years now. And that is because we have a wonderful network of treatment services that we hope that we can also connect you with. So we offer residential and outpatient services. I'll start down in Texas, where we have three facilities there: the Right Step Houston, Brazos Valley, which is in College Station, and Promises DFW, which is very new to our family. So down in Texas, we actually started one of the very first mental health residential treatment centers. So if a lot of you are maybe like wanting to learn more about what is specific residential care for Texas, I'm happy to provide information on that. We do a lot of kind of communication around what that is because it is something that is very unique to Texas itself. So also within the Right Step Houston, we offer Medicaid services, and again, Dallas is very new, and so it's if you are interested in a tour of any of those facilities, I'm happy to introduce you to the right people. Also very new to the Promises family is Promises Atlanta. So Promises Atlanta is led by Bill Anderson, who's kind of my cohort here at PBHU. A lot of you may have met him already, and again, they're doing a great work with residential, and they're about to start doing outpatient treatment there as well. So, up in Tennessee, that's kind of our flagship facility at the ranch. So, we offer equine therapy there, which is really special, as well as zip lining and holistic services. It's a huge, expansive facility and offering all levels of care there as well. We also offer virtual outpatient services at the Ranch, Tennessee. We also offer virtual outpatients in Texas as well. I forgot to mention that. So those two states, Tennessee and Texas, we offer virtual care as well. To follow up with the Ranch, Tennessee, the Ranch, Pennsylvania, up near Hanover, Pennsylvania, is actually just um, accomplished its second year being voted top treatment center for Newsweek. So we're really proud of the Ranch, Pennsylvania, and their clinical care up there. Michael Fanjoy, who's the director of outpatient PHP, he's going to actually be speaking at PBHU in a couple of months. He's spoken with us before. He's a really wonderful clinical leader. And then to follow up, Washburn House is in Worcester, Massachusetts, which I almost always say incorrectly. And they actually have one of the longest continuums of care within Massachusetts. So someone can be there for up to almost 9 months. And we're really, really proud of the work that they're doing to provide that care for that really distinct kind of client. Okay, y'all. Again, if you have any questions, want to learn more about our programming, you wanted to speak to one of our clinicians, I'm happy to introduce you. You can email me, callie.boyer@promises.com, or you can email pbhu@promises.com, and that's where we can connect you there too. Okay, go to the next slide. All right, so let's get into webinar logistics. The chat box, which you've all been very familiar with already this morning. That is where you can kind of keep giving questions about technology, webinar functions. Olivia may ask you to like engage with something about the content. Please put that into the chat. I just ask that you keep all the relevant webinar questions that you have for her in the Q&A. We will have a quick 5-minute break today, so she'll come back to questions specifically for content there in the middle and then at the very end as well. So questions about content, please keep in the Q&A. Everything else can go into the chat. Go to the next slide. I also realized that it is June and I have spelled webinar wrong on that slide the whole year. So next year we're going to have it fixed. Or next year, next month, I hope. I've realized it now. I just noticed that. Okay, someone could have told me. You guys have been seeing that for like 5 months. All right, so CE process. You're all here for CEs. Try to miss no more than 10 to 15 minutes of the training. You're all already here, so you're doing a great job. Just know that as well, one login counts as like your sign in. So if you're there sitting with your coworkers in a meeting room, only one of you is going to be getting CE credit. So just make sure you're all logged in on separate devices. You can also travel. So if you're having to move from like your laptop to your iPad or something, the Zoom will follow you, and that's totally fine. And then after the training, of course, you'll be getting an email from CEO, just like you did when you registered and when you signed in today. So that will give you your email reminder to fill out your evaluation, let you know if you passed. And then that certificate will be automatically sent into your dashboard where hopefully all of those will be living together. So at the end of the year, you have them all stored in the same place. Again, this is 2 credit hours with NADAC and NBCC. I know I get a lot of questions as well about specific state licensure, and I typically have to kind of give you all the same response that I don't know every state's requirements. I can tell you what I often see as far as who attends, but just know that if you're curious about your specific state, just recommend checking in with your personal board on that. You can go to the next slide. And I'll also mention, I'll probably have this question again as well, but all the slides, resources that Olivia shares today, we'll be putting those in your attendee dashboard later like next week. So just know that we'll be receiving slides, recording all of that next week. Okay, so next month we have Jamise, and she's spoken PBHU before. She's wonderful, or she's our VP of Clinical Compliance. And she'll be talking about, ethical decision making in behavioral healthcare. So if this kind of content is resonating with you, please come back and see us next month. Uh, this one here in July and also in August, those two are going to be our only CEs that qualify for ethics, CE specifically credits. So if you need ethics credits, come in July and August. And I will drop July's registration link in the chat here when I'm done so you can sign up for that now. Okay, you can go to the next slide. All right, y'all, and I have talked about this in the recent months, but we are starting to offer free family webinars. And so those we've actually expanded it already. So 3 times a month, we are meeting with families. The second and fourth Tuesday are going to be trainings, kind of similar to this. You're going to have one of our clinical leaders speaking for 30 minutes to an hour about different kind of therapeutic modalities that support clients, that support families. When someone gets out of rehab, they typically have a whole new way to communicate and a whole new set of language that they're excited to use. And so we just want to make sure that our families are up to date with what that language is. And so that is what those are open to. And again, it doesn't have to be for someone within our Promises network. If you just have a client that needs a little extra support with a loved one that's either in addiction, in recovery, in treatment, that's who this is for. So it is open to anyone. The second and fourth Tuesdays are the trainings. That third Tuesday of the month is our family support group, which is just an open forum for families to come in and ask questions about anything related to addiction, treatment, and recovery. So, again, you kind of scan that QR code, or you can go to you can email familyservices@promises.com if you want to learn more. And I can put a link to that in the registration as well. But they usually also add them into my email communications to you all. So, okay, Olivia, I think I get to pass this to you now.
Thank you so much.
Great.
And Good morning, everyone. Welcome to Promises Behavioral Health University. I just want to say thank you, everybody, for taking the time to join us this Friday morning. I know we all have very busy schedules, and I truly appreciate you choosing to spend part of your day participating in this training. So, as Callie did a wonderful job, thank you again for introducing me. My name is Olivia DeRozier, and I'm the Director of Medical Compliance and Quality Assurance here at Promises Behavioral Health. So today we're going to be spending about the next 2 hours exploring a topic that really affects every healthcare professional, regardless of their role, specialty, or years of experience. And that's the impact of cognitive bias on pain management. So this isn't a training about assigning blame or suggesting that anyone intentionally engages in bias. Rather, it's about recognizing that our brains naturally rely on mental shortcuts sometimes to make decisions, especially in busy healthcare environments. And sometimes these shortcuts can be rooted in bias or preconceived assumptions. And our goal today is to better understand how this influences the way we assess pain, communicate with our patients, and make those treatment decisions. So we're going to look at the science behind cognitive bias, explore why pain management is particularly vulnerable to bias, review some examples, and really discuss some evidence-based strategies that can help us provide more objective, equitable, and patient-centered care. So my hope today really is that you're going to leave today's session not only with some new knowledge, but with some practical tools that you can apply in your day-to-day to strengthen patient trust, improve clinical judgment, and ultimately enhance that quality of care that we provide every day. So before we really jump into discussing specific types of cognitive bias and their impact on pain management, I'm just going to spend a few more minutes reviewing the objectives of today's session. So by the end of today's session, you're going to be defining cognitive bias and explaining why it occurs. Understanding cognitive bias is very important because recognizing that these patterns of thinking happen and are universal helps us approach the topic with curiosity rather than defensiveness. So we'll discuss why these biases occur, the role that mental shortcuts play in decision making, and why healthcare environments can be vulnerable to these patterns of thinking. So another important objective of today's training is understanding how cognitive bias affects patient outcomes. Because bias does not simply affect our thoughts, it influences the care we provide and the experiences our patients have within the healthcare system. So patients who feel dismissed or misunderstood may lose trust in healthcare providers and become less engaged in their treatment. Over time, these experiences can negatively impact both physical and emotional health outcomes. Understanding these consequences really reinforces why awareness of cognitive bias is essential to patient safety and quality improvement. Now, very important, I'm going to need your guys' help with this because as we move through the remainder of the session, I encourage you to think about your own experiences and write them in the chat. Consider times when an initial impression changed after obtaining more information, where you may have been affected by or observed bias happening around you. Reflect on patients who challenge your assumptions or situations where hindsight caused you to reconsider a decision. Because these moments are opportunities for growth and learning. And we're actually going to be spending a little time discussing some of the examples from the chat later in the training. So cognitive bias is not something that only affects other people. It really does affect all of us. So what do we mean when we say bias? Before we begin discussing how cognitive bias influences pain management, it's important that we first establish a common understanding of what we mean by the word bias. When people hear the word bias, they often think of prejudice or intentional discrimination. And while those issues certainly exist and are important to recognize, cognitive bias is much broader than that. In healthcare, bias can be thought of any attitude, assumption, perception, or pattern of thinking that influences how we interpret information or interact with patients. So, in behavioral health and other clinical settings, bias may affect how we interpret symptoms, assess credibility, prioritize information, or make treatment decisions. Sometimes those biases are influenced by factors such as race, gender, age, socioeconomic status, mental illness, or substance use history. And at other times, they develop because of our own previous experiences with similar patients or repeated exposure to certain clinical situations. One important point I'd really like to emphasize is that bias is often unconscious. Most healthcare professionals genuinely want to provide compassionate, equitable, and evidence based care to everyone. However, even with the best of intentions, unconscious thinking patterns can still influence our clinical judgment. This is especially true in busy healthcare environments where we're constantly making rapid decisions while managing competing priorities. So, all that brings us to the concept of cognitive bias. Cognitive biases are systemic patterns of thinking that can lead us away from completely objective decision making. Rather than analyzing every piece of information equally, our brains might rely on mental shortcuts, often called heuristics, to process information quickly and efficiently. So these shortcuts are actually helpful most of the time. They allow us to recognize familiar situations, respond quickly during emergencies, and make decisions without having to analyze every possibility from the beginning. The challenge is that those same shortcuts can sometimes produce errors in judgment. So, because our brains might rely on previous experiences, first impressions, and familiar patterns to help us interpret new situations, without realizing it, we begin to fill in missing information based on what we expect rather than what is actually present. In other words, we interpret information through the lens of our own experiences and assumptions. Most of the time, this process can happen automatically and really completely outside of our awareness. And healthcare is an environment where this happens every day. Healthcare professionals are constantly assessing patients, interpreting symptoms, reviewing lab results, prioritizing competing concerns, and making dozens of important decisions during every shift. Because we cannot stop and thoroughly analyze every decision, our brains naturally look for patterns. And experience helps us recognize those patterns, but can also create blind spots if we assume that every patient fits what we've seen before. And this is particularly important when we think about pain management. Pain is one of those very subjective symptoms we assess. There's really no single lab test or image study that tells us exactly how much pain a patient is experiencing. Instead, we rely on patient self-report, objective assessment findings, clinical observations, and our own interpretation to determine the best course of treatment. And whenever interpretation is involved, cognitive bias has the opportunity to influence our thinking. Ultimately, recognizing cognitive bias is really about strengthening our clinical judgment. It encourages us to remain curious, ask better questions, seek additional information, and evaluate each patient as an individual rather than relying on assumptions or previous experiences. And by understanding how cognitive bias develops and how it influences our decisions, we place ourselves in a much stronger position to provide that equal, compassionate, and evidence-based care for every patient we serve. Now, what makes healthcare vulnerable to bias? Something to understand about cognitive bias is that sometimes healthcare environments themselves can create conditions for bias to occur. And cognitive bias is not a reflection of intelligence or competence. Rather it can sometimes be a natural consequence of working in environments that demand rapid decisions, constant prioritization, and management of uncertainty. Think about a typical day in healthcare. We're managing multiple patients, responding to interruptions, reviewing lab results, answering phone calls, coordinating with an interdisciplinary team, completing our documentation, and addressing unexpected situations, all while trying to provide safe, high-quality care. And under these conditions, our brains sometimes rely on mental shortcuts, time constraints, heavy patient volumes, staffing shortages, and information overload encourages automatic thinking rather than deliberate analysis. So these shortcuts help us function efficiently, but they also increase the likelihood that assumptions and previous experiences can influence our clinical judgment. Another factor is experience. As clinicians gain experience, they become better at recognizing patterns and making rapid decisions. This expertise is really incredibly valuable and often improves patient care. However, experience can create those blind spots I mentioned earlier. When we've seen the same presentation many times before, it's easy to assume the next patient fits that familiar pattern. And while those instincts can be correct, they can lead to us to overlook important differences. For example, imagine a provider who frequently cares for patients who request opioid medications. Over time, that same provider can become increasingly skeptical when evaluating similar complaints. Or consider a nurse who's cared for many patients experiencing alcohol withdrawal. When another patient presents with withdrawal similar symptoms like agitation or confusion, it can be tempting to assume the same diagnosis before considering other possibilities. In both situations, that previous experience is helpful, but can also shape expectations in a way that influence clinical judgment. So by recognizing the environments in which cognitive bias is likely to occur, we can intentionally slow down when appropriate, question our assumptions, and make those more thoughtful, evidence-based decisions. Awareness is really one of the most effective tools we have for strengthening clinical judgment and providing that safe, equal care for every patient we serve. So as we've discussed, cognitive bias can influence clinical decision-making in many different ways. And there are really multiple forms of biases out there that affects how we assess the patients and interpret information. So on this slide, I've highlighted several biases encountered in healthcare. However, these are not the only biases out there. One example I've put on the slide is implicit bias, which refers to that unconscious attitudes or associations that influence our perceptions and behaviors without us even realizing it. These biases often develop over a lifetime through personal experiences and societal influences, and they can unintentionally affect patient interactions and clinical decisions. Another example is cultural bias. So every patient brings unique cultural beliefs, values, and life experiences into the healthcare setting. And when we interpret another person's behaviors or symptoms only through our own cultural perspective, misunderstandings can occur and important information may be overlooked. You'll also see on the slide diagnostic bias, which is where certain conditions may be overdiagnosed or underdiagnosed based on characteristics such as race, ethnicity, gender, age, or socioeconomic status, rather than those objective clinical findings. Similar to that is treatment bias, which occurs when treatment recommendations differ because of because of patient characteristics instead of their actual clinical needs. And finally, we have confirmation bias, which is the tendency to focus on information that supports our initial impression while overlooking the evidence that challenges it. This is actually one of the most common cognitive biases in healthcare and can have a significant impact on pain assessment and those pain-related treatment decisions. So the important takeaway from this slide is not to memorize every type of bias, but to really recognize that there are a variety of biases out there and that they can influence multiple stages of patient care, from the assessment and diagnosis to treatment planning and communication. And as we move through the remainder of this presentation, we're going to be exploring several of these biases in greater detail and discussing those strategies for recognizing and reducing their impact on pain-related and clinical decision-making. So as I said, we're going deep dive into one of those biases, and the first one is confirmation bias. So while there are many types of bias, including the ones listed in the previous slide, let's focus on confirmation bias for right now. And confirmation bias is one of those more common cognitive biases encountered in healthcare. It occurs when we give greater weight to information that supports our initial impression while overlooking or minimizing evidence that challenges it. So in other words, once we form an opinion, our brains naturally begin looking for information that confirms that we're right. And most of the time, this might happen without us even realizing it. In healthcare, confirmation bias can have a significant consequence because many of the decisions we rely on rely on interpretation and clinical judgment. So we're constantly gathering information, forming impressions, and making decisions under those conditions of uncertainty. So when that initial impression is formed, it becomes very easy to interpret everything that follows through those same lens. So imagine being a patient with a documented history of substance use disorder who presents with severe pain. And before even entering the room, the clinician may review the medical record and see that they've had multiple previous admissions, repeated emergency department visits, and a history of opioid use. So if we immediately assume the patient is seeking medications rather than experiencing legitimate pain, we may unconsciously begin focusing on behaviors that support that belief while minimizing those objective findings that suggest the patient's pain is real. We might not be intentionally ignoring information, rather, we're trying to seek consistency with our first impression and thought. And once that impression is established, confirmation bias influences how that information is processed. So the clinician may pay more attention to those repeated requests for pain medication. They may notice previous missed appointments or read comments from prior healthcare providers describing challenging interactions. They may overlook patient statements where they speak about financial barriers or difficulty for transportation to outpatient appointments. And while some of these details confirm the original suspicion, reinforcing that the patient is seeking medications rather than experiencing legitimate pain. We're not looking at the entire picture. So that information that contradicts that original assumption may receive less attention. Those objective findings, like nonverbal cues, like guarding with pain, limited mobility, changes in vital signs, grimacing, difficulty performing activities of daily living, may be overlooked or minimized. New symptoms may not be investigated as thoroughly because they don't fit the narrative that's already been established. Those societal factors that I mentioned, like the transportation issues and the financial barriers, aren't given as much weight as they could have. So, in essence, the clinician is no longer evaluating the patient objectively. Instead, they're collecting evidence that supports what they already believe and assume. So, confirmation bias is not limited only to patients with substance use histories. It can affect any patient population. If a patient carries a diagnosis of anxiety, you might prematurely attribute chest pain or shortness of breath to a panic attack rather than considering a cardiac or respiratory issue. Or if a patient is frequently admitted or known to staff, they may get a label like frequent flyer that influences how seriously their concerns are taken. The consequences of confirmation bias extend beyond the realm of diagnoses. Patients who feel dismissed or disbelieved often lose trust in healthcare professionals. They can become frustrated, withdrawn, reluctant to seek future care, and those delays in treatment can increase suffering and really worsen outcomes. So, in the context of pain management, confirmation bias really may contribute to undertreatment, unnecessary delays, and disparities among vulnerable populations. Now, fortunately, there are some strategies to reduce confirmation bias. And one of the most effective is simply to pause and challenge your own thinking. Ask yourself, what evidence supports my conclusion? What evidence contradicts it? Could there be another explanation for what I'm seeing? Approaching patients with curiosity instead of certainty encourages more thorough assessments and more balanced clinical reasoning. The goal of healthcare is not to prove ourselves right. The goal is to understand our patients, gather that information, and provide the best care possible. And sometimes that requires us to be willing to challenge our own thoughts and accept that our first impression may not tell the whole story. The other type of bias I wanted to review was implicit bias, which, unlike confirmation bias, which involves seeking information to support an existing belief, implicit bias refers to those unconscious attitudes, stereotypes, or associations that influence our perceptions and decisions without our awareness. These biases develop over time through our life experiences, culture, media, education, and sometimes the messages we receive from society. And importantly, they often do not reflect our own conscious beliefs or values. So, in fact, many healthcare professionals were really deeply committed to providing that compassion and equal care, but you could still have implicit biases that can influence your clinical decision making. So, research has shown us that there are disparities in healthcare that involve race, ethnicity, gender, age, mental illness, substance use history, and socioeconomic status. And these differences are often not the result of intentional discrimination, but rather unconscious assumptions that influence assessment, communication, and treatment decisions. So, For example, minority patients may receive less adequate pain treatment. Women may actually have pain attributed to emotional causes over physical causes. And older adults may have their self-report symptoms of pain dismissed as normal aging. Implicit bias does not always appear as something obvious. More often, it's really reflected in those subtle differences in communication and behavior. So you may spend less time with certain patients. You might interrupt them more frequently. You might provide less education or unconsciously assume they're less likely to follow recommendations. And while all these behaviors may seem small, our patients notice them. And those repeated experiences of feeling unheard or judged can reduce trust, discourage future healthcare visits, and contribute to poorer health outcomes. Fortunately, implicit bias is something that we can work on. Much like cognitive bias, the first step is awareness. We must be willing to examine our own thinking and ask ourselves the questions regarding it. Would I respond the same way if the patient acted different? Am I making assumptions based on the person's background rather than the information in front of me? Could there be an unconscious stereotype that's influencing my clinical judgment? With pain management, using standardized assessments, evidence-based protocols, and interdisciplinary collaboration can reduce that variability in care and help ensure that those treatment decisions are really based on clinical findings rather than assumptions. So the goal is not perfection. The goal is self-awareness and professional growth. And by recognizing that implicit bias exists and intentionally reflecting our own decision making, we help strengthen that patient trust and communication with those patients that we serve. Now, I really love this part right here. The language we use matters because it's so very true. While many of these biases occur silently in our mind, there is one place where they can become visible, and that is in the language we use. The words we choose matter. They matter not only because they shape how we communicate with patients, but because they shape how we and other members of the healthcare team think about our patients. A single phrase documented in the medical record can influence expectations before the next clinician even enters the room. So in many ways, that language reflects and can reinforce cognitive bias. Take the phrase drug seeker or medication seeking. It often develops after repeated encounters with patients requesting pain medications or presenting with chronic pain. The problem is that those labels, like drug seeker, is not a medical diagnosis. It's an interpretation. It assumes that we know the patient's motivation, even though we cannot objectively determine that simply by observing their behavior. Now, let's compare this with the phrase patient requesting pain medication. Do we all notice the difference? This statement simply describes what the patient is doing without assigning motive or intent. It's factual, it's objective, and it leaves room for further assessment. The patient may indeed be requesting pain medication because they're experiencing severe pain. They may have poorly controlled chronic pain. It's possible they could have developed an opioid use disorder. Or there might be another explanation entirely. At this point, We wouldn't know. Our responsibility is to assess, not to assume. The same is really true for terms like frequent flyer or non-compliant. Instead of labeling a patient, we can use objective language like patient with multiple healthcare encounters or barriers to treatment adherence. These phrases encourage us to ask why rather than jump to conclusions. Is pain poorly controlled? Are there financial barriers, transportation issues, or other social factors affecting care? Objective language doesn't mean ignoring concerning behaviors. It means describing what we observe rather than assigning motives we cannot confirm. And this promotes more accurate documentation, stronger clinical reasoning, and better communication among the healthcare team. So we're going to take a second and pause and reflect because I'm going to take a few minutes just to hear from all of you. As I mentioned at the beginning of today's session, we have the chat available for you to share your thoughts and experiences throughout the training. So if you haven't already, go ahead and add a response in the chat. Have you witnessed cognitive bias in healthcare? It could be something you observed, something you experienced as part of the healthcare team, or even a situation that made you stop and reflect afterwards. Remember, this is not about placing blame or criticizing anyone's decisions. It's really about recognizing that cognitive bias can influence all of us and learning from those experiences. So I'm going to jump into chat myself, see what we have. Oh, I see all the yeses pouring in. Yes. I've witnessed it in others and myself. I think we all can say that there has been moments where unconsciously we have assumed something about a patient based on other experiences that we've seen. And then over time, when we've questioned ourselves, when we've stopped and said, is that true? We've realized we're wrong. We overlooked something very important. I'm still looking through chat. Thank you, everybody, for all the responses pouring in. Yes, I see one response here. I've noticed older patients in IOP are typically disregarded by other counselors when sharing about pain and other triggers to drink. Yes, they've seen it as well. I thank you for sharing about older patients because that is definitely a form of bias there. It's one I didn't go into, but age-related bias and pain management. We see at times someone will come in and they will report that they have pain, and it will be brushed off as part of the normal aging process. But really, is it? Is our normal aging process to have chronic body aches and two knees that hurt and a hip that clicks every time we walk? Let's think about that for a second and really let's take a step back and say, is this patient in pain? They are saying they're in pain. How can we help them? How can we improve their quality of life? I saw someone else mention about also about pain and drinking. There is sometimes combinations there. Someone, if they can't get to their outpatient appointments, might go to substance abuse or alcohol abuse to help with pain management in a way. So it's not something that everyone sees, but definitely is out there. Oh, thank you for someone. Attention-seeking behavior in psych. How true is that? I'm going to raise my hand here as well. Have we all heard someone say attention-seeking behavior in psych? I have, for sure. I've heard many coworkers say that. Someone is yelling, someone is screaming, someone is faking having delusions because they're attention seeking. We don't know. We're assuming. We're at that point, we we're not using our objective clinical assessments there. We're seeing something going on with the patient, and we're assuming, and we're assigning a label to them that is going to influence everybody that comes afterwards, especially if that ends up in our documentation. Thank you, everybody. And I encourage you to keep putting in chat your thoughts and your experiences regarding this, because as you can see, cognitive bias and these situations are universal. They happen around us. They sometimes happen to us. And unfortunately, sometimes we also do them as well. Doesn't mean that we're not trying to provide compassionate care. It means that sometimes we make assumptions, but what's most important is that if we see that happening, whether around us or that we're doing it, we stop and we take a step back and we say, was that the right thought? Am I jumping to conclusions? Does the evidence I see in front of me support that thought? Or am I filling in the gaps to create my own narrative to support what I'm assuming is going on? So let's jump more into pain. Let's talk more about pain specifically. Although pain is one of those most common symptoms encountered in healthcare, it's also one of the most complex. Modern science tells us that pain is much more than a physical sensation. It really is a multidimensional experience influenced by biology, emotions, previous experiences, culture, and a patient's expectations. So, understanding this complexity helps explain why pain management requires both knowing the science behind it, but also a wealth of empathy to our patients. So, pain is defined as the unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And this definition helps remind us that pain is both that physical and emotional experience. So while nerves and pain pathways alert us to an injury, our thoughts and emotions influence how that pain is perceived. So because of this, two patients with the same exact injury may report very different pain experiences, and both experiences can be equally valid. So, some information. Pain is commonly divided into four categories. You have acute pain, which occurs immediately after an injury, a surgery, or illness, and generally improves as the healing occurs. You have the chronic pain, which persists beyond that expected healing period and often involves more of those biological, psychological, and social factors. Neuropathic pain results from an injury or dysfunction of the nervous system and is often described as maybe burning or tingling or shooting. That nerve pain we hear our patients report sometimes. And nociceptive pain results from the tissue injury or inflammation and can be described as maybe aching or throbbing. So, understanding these different types of pain can sometimes help guide treatment because no single intervention is appropriate for every single patient. There's no one size that fits all for pain. We got to look at everybody individually. And so, something to remember is that pain can't be measured with a lab test or an image study. There's no single lab test out there that tells us, oh, this person is in X amount of pain. Much of our assessment relies on the patient's self-report, clinical observations, objective assessments that can be utilized, and professional judgment. That's exactly why pain management is so vulnerable to cognitive bias. Because whenever we have that interpretation that's required, our assumptions and previous experiences have the potential to influence our decisions. So, as we're continuing through today's training, I want you to keep in mind that pain is far more than just a symptom. It's actually a full human experience. And recognizing that complexity helps us provide that more compassionate and individualized care. So let's talk. Why does pain management matter? And it matters because so many of our patients are in healthcare have complaints about pain, acute pain, chronic pain, horrible pain, bad pain, small pain, big pain. We hear about it every single day. Whether you work in emergency medicine, behavioral health, primary care, rehab, long-term care, pain is something that's out there and we see it every day. Sometimes we deal with pain ourselves as the professional, chronic pain that we have to manage in our day to day. So while pain is a universal human experience, it remains a very challenging symptom to assess and manage because every patient experiences it differently. So pain affects much more than physical comfort. It influences sleep, mood, mobility, relationships, participation in treatment, and really overall quality of life. Poorly controlled pain can increase anxiety and depression, interfere with healing, reduce participation in therapy, and lead to that prolonged recovery or repeated healthcare visits. Effective pain management is not simply about making patients comfortable. It's about reducing suffering and improving that function and supporting recovery and helping patients maintain the best possible quality of life. And that challenge with it is that pain's subjective. Two patients with the same diagnosis or injury may describe very different pain experiences. A person's emotions, previous experiences, culture, trauma history, coping skills, support systems, all influence how pain is perceived and expressed. Because pain can't be measured with, a single lab test, we have to rely on the patient's self-report, careful assessment, objective findings, and our own clinical judgment. And that is all what makes pain vulnerable to cognitive bias. So, unlike blood pressure and heart rate and those, clear-cut lab values that we get, pain has that interpretation. Our own assumptions, previous experiences, and unconscious biases can influence how we assess pain, how seriously we take a patient's pain concern, and ultimately how we treat them. And sometimes patients with history of substance abuse, mental illness, chronic pain, those repeated visits, healthcare encounters can become vulnerable to these biases and assumptions. Let's think about ourselves. If we deal with chronic pain or if we have seen multiple patients who have chronic pain, we can approach a new patient sometimes who have similar diagnoses or similar situations. And we might find ourselves saying, well, I have the same diagnosis and I deal with the pain just fine. Why can't they? Or I've seen patients come in multiple times with pain and for this diagnosis, and no one's reported a 9 out of 10 on the scale. Why is this patient so high? Maybe they're just drug seeking. It's their fourth time in the emergency department. Sometimes we might overlook emotional pain and distress. As I said, our patient's mood and history and trauma can seriously affect how their pain is presented and how it's coming across to us. And a lot of those we can't see. We can't see how they're feeling. We can hear, all we can do is hear their report and with compassion and empathy, assess the patient and give them the best care possible. And that leads us into the next slide. Pain is whatever the patient says it is. As I've said before, important principle is that pain is subjective. You've probably heard it before. I've heard it many times in healthcare. Pain is whatever the patient says it is. So while this may sound really simple, it reflects a very important reality of practice. Unlike those objective things like blood pressure and heart rate, there isn't that single test to use. So the patient's self-report remains the gold standard of pain assessment. Now, that doesn't mean that pain assessment is based solely on what the patient tells us. Effective pain assessment combines that subjective patient report and objective information. We, of course, listen to the patient's description of their pain, but it's important that we also do the physical assessment. We observe any functional limitations. We review their vital signs, evaluate diagnostic findings, and use validated pain assessment tools like a numeric rating scale or another standardized pain assessment tool to create consistency in how we evaluate pain and reduce variabilities between providers. It's important that patients don't feel like they're treated differently from either nurse to nurse or doctor to doctor or clinician to clinician, that we're all using our standardized tools and assessments so that each patient feels like they are being treated equally with everybody that's serving them. And these tools don't replace that clinical judgment, but they provide that objective framework that ultimately supports it. But even with those standardized tools, clinical judgment remains very important because pain is highly individualized. As I've said many times before, two patients with the same injury or diagnosis can have very different pain experiences. One person might openly express discomfort, while another remains really calm and stoic despite feeling significant pain. And neither response tells us whether the pain is more or less legitimate, because pain expression is influenced by many factors, including the patient's personality, their culture, their previous experiences, anxiety, trauma, coping mechanisms, family expectations. So this is where that cognitive bias comes in to support our decision making, because pain requires interpretation. There's an opportunity for our assumptions to shape the way we assess patients. Like if we see someone with substance use disorder, chronic pain, and frequent emergency department visits, we're looking at the medical record and we see that before we ever meet the patient, we might begin forming a conclusion before the assessment even starts. And before we even walk into the room, we might become skeptical of the patient's pain report or really focus in on that information that confirms our initial impression while overlooking all that evidence that challenges it. So what I just described is really a classic example of that confirmation bias. It's really important to remember our responsibility is not deciding whether a patient's pain is real. It's about performing that thorough assessment and getting both that subjective and objective information to identify those potential causes and develop an appropriate treatment plan. Ask yourself instead of, do I believe this patient? A better question is, what information do I need to understand this patient's experience? Because that small shift moves us from being judgmental to being more curious and really encourages us to have more thoughtful clinical reasoning. Now, I am going to give everybody a about 3 to 5 minute break. And when we come back, we can step back in and go more into those factors influencing pain and answer some questions. Hello, everyone, and thank you for that short little break. I know this is a lot of information to take in and process, so I want to give people an opportunity to get their questions in chat, and also our Q&A and go over them before we keep on deep diving into pain and cognitive bias. So one question I wanted to answer, chronic pain submitted in Q&A, chronic pain often leads to depression and anxiety, but if patients admit this, then they're often denied certain medical procedures by insurance. How should patients and physicians ensure that they get the help that they need, both emotionally and physically? I think this is an excellent question because it is a very difficult topic to go over. And I say that because pain involves more than just the body and those physical symptoms. When our patients are dealing with, especially chronic pain, it can lead to that depression and anxiety. It can affect their day to day. They might have to go on FMLA for work. They might not be able to work at their old job anymore, depending on the injury or the chronic pain. And those emotions at the end of the day are very valid. And I think that's important to remember. They are valid and they might not just go away once that surgery or a procedure that they need gets done. They're still going to be there because that pain caused by that injury might have long lasting effects on them. And it might have gone on so long that's affected their relationships. They might have been cranky. We all get cranky when we are going through pain. And now people don't talk to them or they've had to go through a lot. So I would say, how should patients and physicians ensure they get help they need both emotionally and physically? By having multiple people involved, like a disco ball, have their care be multifaceted. Don't only focus on one thing. Don't only focus on the pain or the surgery or the procedure that you need to get to there. Have them see a therapist. Have them see a psychiatrist if they need to. Have them get the care that they need to be able to develop those coping skills and getting a recovery environment at their home with whatever social support they have available to them so that they can be successful long term. Because really, that's what we're looking for with our patients. Not a quick fix, not a one size fits all answer or pill or a magic sentence that makes everything better. We're really looking for our patients to have that long term success down the road so that they can have the best quality of life that they can. It might not be the quality of life they had before, but helping them get to the best that they can right here, right now in this moment. There's a few more that's popped up. We're going to have little bit more time for questions later on because I want to get through some more of the slides. And we'll touch on factors influencing pain and those consequences of uncontrolled pain. So we've touched on a little bit the factors that influence pain. And while those physical symptoms, that tissue damage certainly contributes to pain, it's not only one part of the picture. Pain is that complex human experience influenced by the biology, emotions, past experiences, culture, a person's environment. This is why those two patients with that same diagnosis are describing their pain very differently, because pain is a very personal and unique experience. So those biological factors, the inflammation, the nerve injury, chronic disease, and age all influence how pain is processed. But those emotional factors, like what I just went over with that question, is just as important. Anxiety, fear, stress, depression can all actually increase the pain perception, while reassurance, trust, feeling supported actually can reduce it. Previous traumatic experiences, especially those involved with maybe the initial injury or illness, can also change how the nervous system responds to painful stimuli. What we might not immediately think either is that social and cultural factors play a role as well. So some patients are raised to openly express pain, while others might be taught more to hide it or push through it. There could also be financial stress, unstable housing, limited access to healthcare, a lack of social support, and all of this can make pain more difficult to manage. And these factors don't necessarily change the underlying medical condition, but they absolutely influence how pain is experienced and how patients cope with it. So understanding how these influences is important because many of them are invisible. We can't see the patient's anxiety. We can't see their previous trauma or their cultural beliefs simply by looking at them. If we're not careful, it's really easy to assume that pain should look the same in every single patient. And those assumptions create those opportunities for cognitive bias to influence our clinical decisions. And when pain is underestimated or inadequately treated, the consequences extend far beyond just discomfort. So that uncontrolled pain activates the body's stress response. The physical side of it is that it increases the heart rate, the blood pressure, muscle tension, oxygen demand. The other side is that it interferes with sleep, limits mobility, delays healing, makes it more difficult to patients to participate in their counseling or physical therapy or many of the other aspects of treatment that we're asking them to do while they're at our facilities that support recovery. The emotional side of it is really just as significant. So that pain is associated with anxiety, depression, frustration, social isolation, reduced quality of life. It affects their relationships, their ability to work, their independence. And over time, these physical and emotional effects from pain often start reinforcing each other, creating this cycle in which pain worsens emotional distress and emotional distress increases pain. And this is where really today's discussion is coming full circle. Because pain is influenced by so many factors, and because so many of those factors cannot be objectively measured, pain management depends heavily on that clinical judgment, which makes it subjective and vulnerable to cognitive bias. If we're relying on our assumptions instead of a comprehensive assessment, we really risk overlooking those important contributors to a patient's pain or underestimating how significant this pain is affecting their life. So, one way to reduce cognitive bias is to use a patient-centered approach to their care. Throughout the training today, we've discussed how assumptions can influence pain assessment and treatment decisions. Patient-centered care helps interrupt that process by shifting our focus away from our assumptions and towards understanding the individual sitting in front of us. So patient-centered care recognizes that patients are active participants in their healthcare and not passive recipients of treatment. While healthcare professionals bring so much clinical knowledge and experience to the table, we need to remember that patients are the experts of their own lives. They understand how their pain affects their daily lives, what treatments have or have not worked in the past, what concerns they have, what goals matter most to them. And when we take the time to understand those experiences, we can make better informed clinical decisions. And one key principle of patient-centered pain management is recognizing that success looks different for every patient. As clinicians, it's very easy to focus on maybe just reducing a pain score. But patients often define success in terms of function or quality of life. So one patient, their goal may be that they simply want to sleep through the night without pain. Another person, their goal may be that they want to return to work or be able to participate more in physical therapy, or if they're of age, play with their grandchildren. And understanding these goals allows us to develop treatment plans that are both clinically appropriate and meaningful to the individual patient. And communication is so central to this process. Instead of assuming we know what the patient wants or needs, we have to ask them. We have to listen. We have to encourage the questions and invite the patients to participate in decisions about their care. And these conversations not only strengthen trust, but they reduce that cognitive bias by replacing assumptions with information. So every time we ask, what matters most to you? Or how is this pain affecting your life? We actually gain valuable insight that can't be found anywhere else. And this approach is part of the shared decision-making model. It doesn't mean that patients make decisions alone. It doesn't mean that clinicians abandon their professional judgment. Instead, it combines our clinical expertise with the patient's values, preferences, and goals, and develop a treatment plan together. And research shows us that patients who are actively involved in their care are actually more likely to follow through with treatment recommendations. They're more likely to remain engaged in therapy. And overall, they report greater satisfaction with their healthcare experience. So the patient-centered care reminds us to see the person before the diagnosis, because every patient has their unique story. And understanding that story helps us provide more of that individual equal care. And patient-centered care is the practical application of really what we're discussing today. When we listen carefully, remain curious, involve patients in their decisions about their care, and we do not make assumptions, and we step back and we ask, why? instead of saying, I already know. We reduce the influence of cognitive bias and improve the quality of the pain management that we provide. So, one important thing to discuss, what are the barriers to effective pain management? Because not all barriers look the same. And despite decades of research and our significant advancement in healthcare and pain management, many patients continue to experience chronic pain or undertreated pain. And the reason is not always a lack of treatment options. Instead, effective pain management is often influenced barriers that exist at maybe the patient level, the provider level, or even the healthcare system level. And recognizing that the patient might have these barriers is important because we might not be able to improve their pain management if we don't understand what stands in the way of that. So, patient barriers. Patients might hesitate to report pain or discuss treatment openly. They might worry about becoming dependent on pain medication, or they fear they might be labeled as a drug seeker or a medication seeker, or they might get a substance use diagnosis like opioid use diagnosis that is not really appropriate or applicable to them. They might not want to appear weak or difficult or like they're just complaining. And patients who previously felt dismissed by healthcare providers may avoid seeking care altogether or underreport their symptoms because they don't think they'll be taken seriously. They might underreport their symptoms because they have a family history of addiction and they don't want to fall into that category, or they don't want to risk developing that in themselves as well. There might be financial concerns, transportation issues, limited health literacy, and cultural beliefs that influence how our patients describe pain and whether they're able to follow through with those treatment recommendations. Now, I mentioned provider-related barriers, and those are equally important. Over the past 2 decades, the opioid epidemic has understandably changed the way healthcare professionals approach pain management. And clinicians are expected to balance two equally important responsibilities: relieve the suffering while minimizing harm. And this balance can be challenging. There's concerns about addiction, regulatory oversight, organizational policies, professional liability that can cause providers to become overly cautious, even when opioid therapy is clinically appropriate. And while caution is necessary, it's important that our decisions are always guided by an individualized assessment and not that fear alone. And this is where cognitive bias also becomes important because it can influence that pain assessment and decision making. Those patients with that chronic pain, a history of substance abuse, multiple emergency department visits may be viewed differently before the assessment even begins. And those assumptions can affect communication. They could delay treatment. They could contribute to disparities in care. Our healthcare system presents another set of challenges because most clinicians work in environments characterized by heavy patient volumes. There might be staffing shortages. There could be frequent interruptions in your day, time pressures. And under these conditions, taking the time to do a comprehensive pain assessment can become more difficult. And clinicians could start finding themselves relying more on assumptions rather than making decisions efficiently. And as we discussed, these are the exact conditions that cognitive bias is likely to occur. if our patients have limited access to physical therapy, behavioral health services, pain specialists, or other non-pharmacological treatments in their area, and that can further complicate care and limit those treatment options that otherwise could be very beneficial to them. And although some of these barriers are outside of our immediate control, there is one barrier that is within each of ours ability to address, and that's our own clinical decision making. So by slowing down, using standardized assessments, asking additional questions, collaborating with colleagues, and practicing patient-centered communication, we reduce the influence of cognitive bias and make those more thoughtful, evidence-based decisions. Now, again, everybody, take to chat. If you want to, please feel free to chime in with these questions because we have a case study here. And I want to know your thoughts regarding this case study and if you can identify some of these questions and the cognitive bias in here. So we have a patient with a history of opioid use disorder that presents to the emergency department with severe abdominal pain. Before entering the room, the provider reads the chart and sees the multiple prior ED visits, previous opioid prescriptions. And during the assessment, the patient is repeatedly asking for pain medication. And the provider documents the patient as drug seeking and delays doing any further evaluation. So, what cognitive biases can be influencing this decision? What objective information should be gathered before reaching a conclusion? How can this affect those patient outcomes? And what can the provider have done differently? I see chat already going off. Yes, thank you, everybody. Labels, you all caught that. Labeling, drug seeking, dismissing her needs. Someone even called it out, confirmation bias. Listen more to her symptoms. All of this is exactly true. Talking to the patient instead of labeling. Wonderful, wonderful responses, everybody, because it's true. The doctor walked into this and with a pre-established thought and belief on the patient and assumed they were seeking drugs and discounted what they could have done differently, which is a full assessment. They could be having severe health issues. I'm reading chat as I'm speaking, and you guys are the smart individuals. Absolutely. They could have done a pain assessment tool. They could have reviewed a physical assessment, seen any findings, really deep dived into what was going on with this patient. Because we had that confirmation bias. We had the implicit bias, those unconscious stereotypes about the patient's health, which was the multiple previous ED visits, the opioid prescriptions. A history of substance use disorder is a risk factor, but it's not a diagnosis. Every patient deserves an objective assessment based on their current clinical presentation. And our role is not to determine whether a patient deserves pain medication, but to assess the patient's current condition, identify the cause of their pain, and develop the safest, most appropriate treatment plan based on that evidence rather than assumptions. I got another case study right here, a little bit shorter, not any less important. So a 72-year-old patient reports worsening knee pain and difficulty walking. Staff respond by saying, well, that's just a part of getting older. What assumptions here are being made? How could the clinician rephrase their response to be more patient-centered? And what information still needs to be assessed? I see age discrimination. Chat is blowing up with age discrimination. And you are on the right track there, because this is age-related bias. An elderly patient comes in, is reporting a type of pain, which can be part of the normal aging process, but they're dismissing some key facts that even we're seeing right here in this case study, which is worsening pain and difficulty walking. And those are two big red flags that tells us that if we step back and we say, what's going on with this patient? What are they telling us right now? That would tell us that isn't part of the normal aging process. Now, how can the clinician rephrase their response to be more patient-centered? Let's start with questions. Let's talk more about your pain. Tell me how this has changed. What activities has this pain prevented you from doing? Any of those three questions are not only leading questions, but they also open the door for the patient to be able to fully explain what's been going on with them and us to gain that insight into being able to better understand the patient and create a treatment plan that works for them. Because growing older increases the risk of certain conditions, but it should never be used as an explanation for pain without first completing a comprehensive assessment. Now, last case study. I still want you guys all engaged, even though this is a long one. We have a 39-year-old patient that's admitted to a residential substance use treatment facility. This is his third admission within the past year. And during the admission assessment, the patient tells staff, I know I've struggled before, but I'm really motivated this time and I want to get it right. The patient is currently homeless and has a history of not attending outpatient appointments or following through with healthcare housing recommendations. This is also the third time the assigned case manager has worked with this patient. And based on the previous admissions, the case manager spent significantly less time meeting with the patient compared to other patients. Instead of reviewing housing options, scheduling appointments, and discussing discharge planning, the case manager provides the patient with a packet of community resources saying, he already knows what's available, we've done this before. So let's talk this through. What assumptions are being made? What cognitive biases or biases may be influencing the case manager's actions? How could this approach affect the patient's recovery and treatment? How could the case manager provide a more patient-centered care in this? I see, yes, some great insight here. Assuming he will fail. Assuming he's just looking for a place to stay. Assuming that future performance will be the same as the past and the client is not taking help seriously. Another great one here, that this time won't be the time. He's not going to follow through. Confirmation bias. All 100% accurate, because what this case manager has done is assumed, based on previous encounters, they know exactly what's going on with the patient. He's just going to do the exact same as he's always done before. And this actually brings us into a bias that we've not really touched on a lot, but is very true and applies to this. And that is attribution bias, that the patient's lack of follow-up is attributed to poor motivation or unwillingness to change rather than considering those barriers like homelessness, which we know he has, transportation issues, financial issues, or limited social support. By not going in and taking as much time as they normally would with this patient, they're actually limiting their ability to get part of the full picture with this patient and see, hey, I've talked to you twice before now, and those didn't work. The key, but let's ask, why didn't they work? Were maybe the place is too far away for you to go to your appointments? Did maybe we didn't take into account you wouldn't have reliable transportation? That friend that said he was going to be your driver turned out not to be the driver or not to be a reliable transportation friend. There's so many things that can go into this specific scenario that if you don't take the time and you let those biases make assumptions, you are not being able to create a strong recovery environment for those patients. Because discharge planning, whether it's for social issues, housing issues, or outpatient appointments for pain management, is all 100% important. Now, the next slide we won't spend too much time on. They are examples more of bias found in pain management. So, like the case studies we discussed, cognitive bias does not always appear in obvious ways. It sometimes shows up in everyday clinical situations like the ones here. So, here are a few additional examples of cognitive bias and how it influences pain management. And as you read through them, I want you to ask yourself, what assumptions are being made? What bias might be present? And how can that affect the patient's care? And you might actually find yourself thinking that you recognize some of these examples from past experiences or interactions with patients. These are a few more examples of bias in pain management. As we said in those previous examples, here's one. A healthcare professional may use personal beliefs or stereotypes based on the patient's demographics or social history to underreport or delay treatment of a patient's reported pain level. A woman may be dismissed as being more emotional. A Black or Hispanic patient may receive less pain management due to the belief that they have a higher pain tolerance compared to a Caucasian patient. Older adults may have their pain minimized due to the assumption it's caused by the normal aging process. So, cognitive bias is not a one size fits all, just like our patient's treatment is not a one size fits all. There's so many different examples and ways that it can show up in day-to-day interactions with our patients. Now, the importance of that objective pain management. So as we've said, there's no one single thing that tells us exactly what is going on with the patient, except for the patient's own report. And that means that also relies on our clinical judgment. And that means that cognitive bias has the opportunity to influence our decisions. That's why an objective approach is so important. Because being objective doesn't mean we ignore the patient's experience or become less compassionate. It actually means the opposite. It means combining empathy with evidence-based assessment. It means we listen carefully to what the patient's telling us. We acknowledge that their pain is real, and then we perform a thorough and consistent assessment using standardized tools, those objective findings, and sound clinical reasoning. So in this case, compassion and objectivity are not opposites. They're actually really working together to help us provide the patient with the best possible care. So an objective report approach helps us reduce the influence of bias. And by following those assessment process for every single patient, we reduce the likelihood that those assumptions will influence our decision. Instead of asking, do I believe this patient? We ask, what does my assessment tell me? And this is also essential for patient safety. Undertreating pain can delay healing, reduce mobility, increase anxiety, and erode trust. Whereas, on the other hand, overtreating pain can expose the patient to unnecessary side effects, oversedation, respiratory distress, and other medication-related risk. So our responsibility is to find the safest and most effective balance for each individual patient. And that balance is best achieved through that comprehensive assessment rather than our assumptions or just a routine practice. Now, objective pain management leads to better outcomes. We've talked a little bit about why an objective approach is so important, and let's see what it actually can accomplish in the clinical practice. First, it promotes fairness and consistency. One of the greatest strengths of standardized assessments is that they encourage us to evaluate every patient using the same process, regardless of who they are or what assumptions we may have unconsciously brought into the encounter. It helps us build patient trust because patients remember how they were treated just as much as they remember the treatment itself. When our patients feel like their concerns are taken seriously and that they're being assessed fairly, they're more likely to trust their healthcare team. And that trust helps encourage that honest communication and greater participation in treatment and a stronger therapeutic relationship. An objective approach helps us avoid that undertreatment and overtreatment. And sometimes we worry about giving too much pain medication, particularly in today's healthcare environment. And other times, cognitive bias may lead us to underestimate a patient's pain and provide inadequate treatment. Neither extreme serves the patient well. And the goal isn't simply giving more medication or less medication. It's to provide the right treatment for the right patient at the right time. And this is by using that comprehensive assessment, that thoughtful clinical judgment, and that ongoing reassessment to see if our treatment interventions are working. And if they are, continuing. If they're not, adjusting to better help the patient. So what are some of the best practices for that objective pain assessment? One of them is to use those validated pain assessment tools and following a consistent assessment process for every single patient. Standardized tools, as we know, don't replace clinical judgment, but they provide a structured framework that helps reduce variabilities between providers. So when we assess every patient using the same approach, we're less likely to let personal assumptions or previous experiences influence our decisions. It's also important to remember that no single assessment tells the whole story. High quality pain management combines that subjective and objective information. So the patient's self-report remains an excellent source of truth, but we also have to consider those physical findings, the vital signs, the functional limitations, those nonverbal behaviors to see the overall clinical picture. And when we look at these multiple sources of information, it helps us create this more balanced and evidence-based decision and treatment plans for the patient. Because pain's not static. You don't have the same pain level every single moment of every single day. So our assessments shouldn't be one assessment and then we're done. Reassessing pain throughout the treatment helps us determine whether interventions are working, whether treatment needs need to be adjusted, whether new symptoms require additional evaluation. Consistent reassessment and documentation improves that communication across that healthcare team and supports that continuity of care. So, a little bit on tools for assessment of pain. And I've put 3 up on the slide for you guys. You have your visual analog system, which many of us probably find very familiar. The numeric rating scale. Tell me a score of 0 through 10 on what your pain is, as we all know and love. And then the Wong-Baker Faces Pain Rating Scale, which is more point to what your pain is. Compare it for that. One of the most effective ways to reduce bias is using a standardized pain assessment tool. And these tools provide that consistent framework for evaluating pain and help ensure that every patient is assessed using that same approach rather than relying solely on individual impressions or assumptions. And while no tool can completely eliminate bias, the standardized assessments help promote the more objective and equitable patient decision making. Now, I do want to take a second to touch on common challenges and medication requests. Because requests for medications are a perfect example of encounters that can be challenging for both patients and healthcare professionals. And it can be in a situation where unconscious assumptions can influence our judgment, like where patients make frequent requests for pain medication. When you hear the request repeated multiple times over the course of a shift, clinicians can begin to start wondering whether the medication is truly helping or whether there might be something else going on. The important thing to remember is that the request for medication is actually information. It tells us that the patient's current pain management may not be meeting their needs, but it doesn't tell us why. So rather than assuming the patient is exaggerating pain or seeking medication for inappropriate reasons, the next step really should be more further assessment, taking a step back and asking that why. Has the patient's condition changed? Has their pain increased? Is the medication providing adequate relief? Are they experiencing breakthrough pain? Something our patients can go through, but also something that gets forgotten about sometimes. And if these requests are continuously repeated, it really should prompt communication with the prescribing provider. Instead of being viewed as a behavioral problem, we can really utilize this to consider a more complex pain profile and improve their treatment here. The patient's pain medication may need to be adjusted. There might be additional assessments that need to be done. So it's important to not just say, why are they asking for this pain medication over and over again? Why isn't the patient responding the way that I expected? The better question is to say, what does this patient really need from me today? How can I really help the patient do better, feel better, and meet their needs? And one way to help with that is have a medication request checklist. And that what this checklist is created to do is to reduce bias, to have a consistent process where we follow every time we encounter a challenging situation. It's not meant to replace clinical judgment. It serves as a reminder to slow down, gather information, and make those decisions based on evidence rather than assumptions. You step back and you evaluate the patient's history. Look at what's in the medical record. Determine what is going yourself. Has anything changed since the last encounter? Is there new information that needs to be considered? Then stop and assess the current pain. Do that comprehensive pain assessment that's so important we've talked about. Listen to the patient describe their pain. Use your validated pain assessment tool, evaluate their functional status, look for objective findings that support the clinical picture, and reassess along the way as well. Check the documentation. Good documentation tells the story of the patient's pain over time. So look back in that patient's history. Is the patient's pain improved? Today it might be 6 out of 10, which is maybe higher than the patient wants. But yesterday it was 8 out of 10. We're moving in the right direction. Even though it's still high, there's been a little bit of improvement. Has it worsened? Has it remained unchanged? Have we been doing the same intervention since day one and the patient's not getting any better? Because it might be time to change those. Are they effective? Is there that breakthrough pain that I mentioned earlier? Consult your protocols and look at alternatives. Now that you've gathered that information, collaborate with the medical team. Look at what you're doing for the patient and say, is this working? Is this what we need to continue doing? Do we need to re-educate the patient, help them along? And when you look at this checklist as a whole, you'll notice that every step encourages us to pause before reaching a conclusion. Instead of just reacting to the medication request, we gather information, we perform a thorough assessment, we review the findings, and we consult those evidence-based practices and communicate with the healthcare team. And all of this is exactly how we reduce the influence of cognitive bias. So as we've said, that objective decision-making in those medication requests is a challenging area because sometimes these require quick decisions. And we have to have careful judgment and aware of safety concerns. And we also need to be aware that this is where cognitive bias can easily influence care. A patient's history, their frequency of requests, the diagnosis, the prior documentation may unintentionally shape how we respond before we ever complete a full checklist or do a medication-related checklist or do a full assessment. And that's one reason why to reduce that is to have our protocols, because our protocols help create consistency. We create a shared framework for decision making so that pain management decisions are guided by clinical standards rather than just personal judgment. And again, this does not mean protocols are replacing critical thinking. It means that we're using our tools to help support our objective decision making. And sometimes that also requires us to consider alternatives when appropriate. When it comes to medication adjustment, sometimes we don't go straight to pharmacological. We use non-pharmacological options, hot and cold therapy, relaxation techniques, a broader view of the patient's pain management. By looking at the patient as a whole, having clear documentation, we use our protocols that helps us reduce those cognitive biases and supports patient safety. So we've spent a lot of time talking about cognitive bias, and in a way, this is a recap slide to go over the consequences of cognitive bias. Because cognitive bias does not only affect us exactly in the moment, It affects our patients and it can affect our patients long term. It can lead to misdiagnosis or delayed diagnosis. It can affect their trust. It can contribute to healthcare disparities because those demonstrated differences in assessment, treatment, outcomes among those patients of different races or genders or backgrounds, or whether they have mental health or substance use disorders, they're they can unconsciously influence clinical decision making, judgment, communication, and affect the patient long term. It can be a patient safety issue. It can lead to delayed treatment, undertreated pain, poor outcomes. So, the good thing to remember is that awareness gives us the opportunity to improve by slowing down, questioning our assumptions, approaching each patient with curiosity rather than certainty. We strengthen our clinical judgment and provide safer, more equitable, compassionate care. And the last thing I'm going to recap on is those strategies to reduce the cognitive bias. Because throughout this presentation, it's not been just information. We've tied into those strategies to reduce those cognitive biases. And that really starts with stopping with ourselves and pausing and asking what's going on, slowing down, questioning your assumptions, using your standardized assessments, consider alternative explanations, talking with your colleagues, or consulting your interdisciplinary team, and constantly staying curious. Because where cognitive bias really can come in is when we stop being curious and we start being judgmental and we start assuming and we start filling in the gaps, thinking that we know what's going on, even though we don't know everything. So I just want to take a second to thank everybody for coming in. I know this ran a little bit longer than expected. I do might have time for one question in there, but again, thank you everybody for joining, and I hope that you walked away from this with something a little bit more knowledge on cognitive bias and its effect on pain management, knowing that this training was not something intended to uh, be confrontational or assigning blame or saying that anybody in this chat is doing bias consciously. It happens. But what's most important is that we have awareness regarding it. We know how it affects our patients, how it affects pain management in the short and long term, and how we can walk away from our interactions with our patients knowing that we provide more compassionate, equitable care by not engaging in bias, asking those questions, really getting involved with them and knowing what's going on with them. So thank you everybody for joining in. Thank you for participating in the chat and asking those questions. I've thoroughly enjoyed everybody.
Thanks, Olivia. This was awesome. I mean, you can see in the chat. I think you did a great job. For those that are asking, yes, we will provide those slides for you next week. And if you did ask a question and we did not get to it, I've saved those from the Q&A, and so I'll perhaps send those to Olivia, and then she can kind of answer some of those extra questions that have come through. So we can send those to you via email next week. Y'all have a wonderful, wonderful weekend. We will see you next month in July. Yes, your eval will come to you right after this. When I hit end webinar, you'll see that eval come to your email. Please fill it out sooner than later, and then the certificate gets sent right back to you. Okay, thank y'all for joining us. Olivia, thank you again. See you
Thank you,
guys soon.
everybody. Have a
Bye.
wonderful Friday.